Welcome everybody to the AGU GeoHealth Early Career Webinar on behalf of the GeoHealth Early Career Committee. Today I am very excited to introduce Amruta Nori-Sarma. Dr. Nori-Sarma is an assistant professor in the Environmental Health Department at Boston University School of Public Health, where she studies the relationship between environmental exposures associated with climate change, including heat, air pollution, and extreme weather events, and health outcomes in vulnerable communities. She also has an interest in evaluating the success of policies put in place to reduce the health impacts of climate change. And before I hand it over to her, I'm just going to quickly go through a couple housekeeping items. Please ask any questions that you have through the presentation to the participant in the chat named Ask Questions Here. Make sure your audio and video are turned off. That's default when you come in, and this presentation will be recorded. So with that, I'll hand it over to Dr. Nori-Sarma.
Wonderful. Thank you so much for the introduction, Beth. And hello, everyone. Thanks for joining for the seminar. As Beth mentioned before, my name is Amruta Nori-Sarma, and I'm an assistant professor in climate and health and also the Biostatistics and Epidemiology Data Analytics Center at Boston University School of Public Health. And I'm really excited to be here today to share my work looking at extreme heat preparedness and human health. So I'll just dive right in. So first, I want to talk about why climate change is a threat to human health. And I really like this figure, which I've adapted from the CDC's third national climate assessment, because I think it shows the many interconnected ways in which climate impacts human health along a host of different axes. So at the very center of this figure, you can see information on the direct environmental changes that occur as a result of extreme climate change, including things like rising temperatures, extreme weather events, sea level rise, etc. And then in the middle layer of the figure, you can see some of the environmental factors that may be changing as a result of these climatic changes, including more extreme heat events, more severe weather, increases in air pollution exposure, etc. And then in the outermost layer of this figure, you can see some of the ways in which human health may be impacted, both chronic and infectious disease outcomes that are associated with these changes in environmental exposures. And my own research really focuses on the upper portion of this figure. I've been very interested in understanding the ways in which climate leads to more extreme weather events, including heat waves and other types of extreme weather. I've been interested in air pollution exposure as well. And I've been interested in overall environmental degradation. And I've also focused a lot of my research on some of the health outcomes that we see here as well, including heat-related illness and cardiovascular disease, respiratory illness, injuries, and mortality. And for the talk today, I'm really going to be focusing on this one component in my research agenda, which is looking at the relationship between extreme temperature and health in urban India, as well as across the United States. And I'm going to bring in a component that was mentioned in the introduction, looking at how we evaluate the effectiveness of interventions, including, for example, heat action plans to make sure that they're working to mitigate the impacts of these extreme heat events. So I'm going to start off just talking a little bit about the relationship between extreme temperatures and health in India. So I thought I would start with a little bit of an explainer about why it is that I choose to look at the relationship between environmental exposures and health outcomes in India. And of course, I have a background in India, my family is from there. But I think that, beyond that, India represents a very interesting opportunity for us to understand the impacts of extreme environmental exposures on health outcomes. And this is for a few reasons that I want to dive into. So there are relatively few studies that assess the relationship between environmental exposures and health outcomes in India. And I think this is because there are some unique challenges to public health research in this resource-constrained environment. But India sits at the intersection of very extreme environments, including high baseline temperatures, high air pollution levels, and also very concentrated centers of urban vulnerable populations. So I think that if we can successfully implement some public health research supporting interventions in this area, we might be able to conduct studies that are able to dramatically improve public health in the region. A lot of previous work in public health in India has relied heavily on exposure response functions that have been developed in other high income country settings, primarily from North America and from Europe, where the studies are relatively more plentiful. We might have more access to health data, we might have better environmental data. However, it's been my contention that there are limitations of extrapolating data from those high resource settings to places like India, where we do have these more extreme conditions, and also there may be underlying differences in the adaptation of the population. The third point that I want to bring up is that I do think that because of these higher baseline exposures that are experienced currently in the modern day in India, there are potential opportunities to take some of the lessons that we learn from conducting studies in places like India that currently experience higher elevated temperatures and higher air pollution exposure levels, for example, and use those lessons in other parts of the world that potentially under a climate change framework could start to experience similar extremes in climate. So a little bit about extreme heat. We know that extreme heat is a recognized threat to public health. Exposure to sustained periods of high heat or heat waves can lead to illness or even death. And here I list some of the different health outcomes that we know are associated with heat exposure, including, for example, from the less severe heat rash and heat stress, all the way to the most severe heat stroke, which can be potentially fatal. And importantly, I want to point out from a clinical perspective that if a patient presents in an emergency room suffering from a heat stroke, that person is likely to look very similar to somebody who presents in an emergency room suffering from a regular stroke. So from the clinician's perspective, it can be really difficult to differentiate between somebody who's presenting with a regular stroke and somebody who's presenting with a heat stroke without the corresponding exposure survey to understand what that person has been exposed to in their environment. But in addition to the direct effects of heat exposure on these different health outcomes, exposure to heat waves can cause stress on underlying physiological systems, which may exacerbate existing medical conditions in people who are already very vulnerable due to existing illness. And so here I've listed some of the additional causes of morbidity or ill health that are associated with heat exposure in patients that may have existing underlying conditions. And I also want to point out that heat waves, urbanization, and climate change are very inextricably linked. We know that cities and urban areas experience higher levels of heat exposure than their surrounding peri-urban or rural environments. And this is due to a phenomenon called the urban heat island effect, where city centers can experience temperatures that are up to a few degrees higher than the surrounding rural areas. And this is because of built environment characteristics, lack of reflective surfaces, and a whole host of other issues that lead to these higher temperatures within city centers. There are also phenomenons of urban microclimates, as well as a reduction in the diurnal variation of temperature that's occurring in cityscapes. And this is important because the diurnal variation is the range in temperature experienced within these cities, considering the daytime high maximum temperature and the nighttime low maximum temperature. And there have been some studies in the previous literature that have indicated that it's as important to have that nighttime cooling off period in order to make residents of city environments less vulnerable to these periods of extreme heat. So without that diurnal variation and that opportunity to cool off in the night, we can see much higher levels of adverse health outcomes that are associated with summertime extreme temperatures in urban environments. And we do know that climate change is expected to increase both the frequency and the severity of heat waves. So as I've mentioned before, I think that lessons from India extrapolated to other parts of the world could potentially inform policies that are intended to mitigate the effects of extreme heat under climate change. But as I mentioned in my brief introduction, there are a lot of challenges to understanding the health impacts of heat waves in India. And the first one that I want to talk about, which might seem like, oh, we should understand this question already, but it turns out that we don't, is what exactly is a heat wave? So it turns out that there is no consistent definition of what constitutes a heat wave, either in the public health epidemiology or in the policy literature. And so that can lead to a lot of complexities, you might imagine, as we seek to understand the impacts of heat waves in different regions, but also as we seek to compare the impacts of heat waves across different regions if there's no standardized definition. And, I've mentioned a lot of the different health impacts that occur as a result of exposure to extreme heat. So one question that we might think about from the outcome side of this question is, how do we estimate what exactly is the effect of this heat wave? How do we estimate the illness or the deaths that are occurring as a result of heat waves? And it turns out that that's not trivial either. So some previous work has looked at all-cause hospitalizations or all-cause mortalities. Other work has sought to identify specific causes, for example, heat stroke. And then you may also think of looking at accidental versus non-accidental morbidity and mortality in this context to try and identify the effects of extreme heat. And then finally, if we think about the implementation of measures to try and reduce the impacts of extreme heat, one of the questions that I've been asked is, well, aren't people in India already used to extreme temperatures? So what is the potential underlying role of adaptation in communities that already experience these high baseline exposures? So I'm going to seek to walk through each of these different questions in my talk today. And this has been an area of focus in my ongoing research across these communities and in other contexts around the world. So I wanted to talk really briefly about how this whole project began. So in 2012 and 2013, I participated in the Fulbright Fellowship Program, and I spent the year in Ahmedabad, which is a city in the state of Gujarat in northwestern India. And the project was motivated by this hospital. This is the Sharda Ben General Hospital in Saraspur in the city of Ahmedabad. And Sharda Ben Hospital is a government facility, and it services some of the lowest income communities that are in the surrounding neighborhoods around the hospital in the middle of the city. And in May of 2010, Ahmedabad experienced a severe heatwave period that lasted from approximately the 17th or 18th of May until probably a little before the 30th of May in the city. And over that period, a pediatrician who was working in their neonatal infant care unit in this hospital noticed that there were a large number of adverse health outcomes that were occurring in infants, in newborns who were born in this hospital in the maternity ward and were being admitted into their NICU. And so Dr. Kakad, who is the pediatrician there, put together a group of colleagues and collaborators to try and understand how could we, in this non-climate controlled environment, this is a government hospital with very low resources, how could they start to reduce some of the adverse health impacts that they were seeing during these summertime periods? And could they start to understand what was the impact of the most extreme heat that was occurring in that summer? So as a Fulbright Fellow, my question was, how many people are actually dying due to extreme heat in India? And so here I present a paper that's from the year 2000 from a colleague who worked at the National Disaster Management Authority. And the National Disaster Management Authority at the federal government level in India is responsible for declaring heat wave periods and also a host of other climate change relevant extreme weather events across the country. And they provided from their data sets and from their reports a table that shows the number of deaths that are attributable to all of the heat wave periods, which are shown in the third column of this table, across the entire country for each of those summertime periods from 1978 until about 1999. And this was at the time the most recent data that were available from the NDMA publicly. And as you can see, in one of the most extreme summertime periods that was in 1998 that they had experienced, the government was estimating approximately 1,500 deaths that had occurred over the course of 33 different heat waves around the entire country of India. And for reference, in 2001, the population estimate, according to the Indian census, was about 1 billion people. So from the data tables that are being provided by the government at the time, you might imagine that this issue of extreme heat isn't actually posing that big of a human health threat. But we thought that this might be an underestimation of the problem. And so the reason we believed this at the time is because the number that you're seeing here, the numbers of deaths in during these heat wave periods, in these summertime periods across these decades, are based on news media reports of mortalities that were occurring around the country. And as I mentioned before, it can be very difficult to quantify the numbers of mortalities attributable to heat exposure from a physiological perspective without the corresponding exposure survey and without the training to conduct that exposure survey. So in that May 2010 heatwave period for the city of Ahmedabad, I worked with collaborators at the Indian Institute of Public Health, the Natural Resources Defense Council, which runs programs in India to focus on combating the impacts of climate health, and several other collaborators, both within India as well as at international institutions. And we were able to work with the municipal corporation of the city of Ahmedabad to collect information from the registrar of births and deaths to look at the relationship between temperature and the numbers of deaths that were occurring in the city for this May 2010 period. And what we show here is in the red bars, we show the daily death counts for 2010. And then in the red line, we show the daily maximum temperature for the weather station that's provided in Ahmedabad over the same time frame. And this is by comparison to the same period, the month of May, and that is in 2009 and 2011. And what you can see is that during this heat wave period, there is a very sharp correlation between the increasing temperature and the increasing number of daily mortalities throughout the city. And we estimated that there was an excess of approximately 800 mortalities in the city during that time period. And this is from work that we published in 2014. So just toggling back to the previous slide where I showed you the number of mortalities that were occurring at the government registration for the entire country of India and for all heat wave periods occurring over that summertime period. And this is showing the number of mortalities that we estimated were attributable to heat during a single heat wave period for a single city. This really seemed to support our hypothesis that the actual burden of this problem was being underestimated at the time. And so there were several policy implications from this research. We were working in collaboration with these different stakeholders, as I mentioned, including government officials, and what we were able to put together was a series of policy briefs that was targeting communication with these different stakeholders to warn them of the threat that extreme heat would pose for members of these different communities. And in addition, we put together posters, both in Gujarati, which is the local language, as well as in English, to post in different communities to try and empower members of those communities to protect themselves during times of extreme heat. We also conducted semi-structured focus group interviews with different stakeholders, including in the top right, I show a picture of myself working and participating in one of these focus group sessions with local clinicians and particularly clinicians who were working in government hospitals to try and enable them to conduct those exposure surveys that we were recommending so that they would be able to better serve their patients during times of extreme heat by recognizing the signs of extreme heat exposure and providing the corresponding appropriate treatment. And then finally, we worked in collaboration with different members of the community, as shown in the lower right in the picture. We posted the same poster board with information about extreme temperatures on the backs of auto rickshaws. We also provided similar hoardings to the public bus system, and there were several other interventions that took place during following summertime periods. And the end result of this project was actually the implementation of the Ahmedabad Heat Action Plan in 2013. This was the first implementation of this heat action plan for the city. It's since been renewed each year. The heat action plan has also been replicated in other cities and states in other parts of India. And local groups are working to follow up with these heat action plans to understand whether they're actually working and effective at preventing some of these dramatic health outcomes that we observed in that first summertime period in 2010. So following this work, my interest was to try and start to understand, I had been focused on this one heat wave period in one city, and I wanted to start to look into leveraging existing data resources to try and understand the impact of extreme heat more broadly across multiple communities in the region. And so in service of that work, I conducted during my dissertation a collection of existing registry data. And this project was really facilitated because India has a collection of all births and all deaths that occurs at the government level as a result of the Civil Registration Act of 1952, which mandates that all mortalities have to be documented within a certain period of time after they occur. This is not done for the purpose of epidemiologic analysis. This is primarily done for the purpose of property transfer. So there are definitely some complexities in using this data for public health. But in this very resource constrained environment, the fact that this systematic data collection is taking place could potentially be a powerful tool for public health. And so I worked with collaborators across these 5 different communities in the northwestern region of India to aggregate daily mortality data for the cities of interest across different timeframes, depending on when the data were available. And in some cases, this really did involve going to local municipal corporations, collecting data that was handwritten in a registry, and transcribing and translating that data and compiling it into a usable format. So this represented a very large data collection effort, data processing and data cleaning. But at the end, we ended up with information on daily aggregated mortalities in these different cities for all or part of the period from 2005 to 2012 with help from our collaborators. And one of the things that I do want to mention is that these cities represent different sizes in terms of the population. And they also represent some of the areas of India that might experience very extreme hot summertime temperatures, including, for example, in the northwestern state of Rajasthan. I worked with the Indian Meteorological Department to collect data on daily meteorological characteristics for each of these communities where a local monitor was available, or from a nearby community where no monitor was available in that city. The IMD operates the collection of these meteorological data, including, for example, daily temperature, information on precipitation, et cetera. And so, one of the things I mentioned is that not every community has a local monitor. For example, the cities of Himatnagar and Idhar in the state of Gujarat share one common monitor. And so for the subsequent analysis that I'm going to share here today, I combine these 2 cities into a single community. It turns out they're about 30 kilometers away from each other. And for this project, I used a couple of different approaches. So I'll just touch on these briefly. I'm not going to go into too much detail on the methods, but I'm happy to talk about those in more detail if they're of interest during the Q&A session. So at first, we used generalized additive models to characterize the direct relationship between temperature and mortality for each of these cities. And then I looked at particular heat wave periods, applying a couple of different heat wave definitions, which I'll talk about in more detail here in a few minutes. And we looked at the relationship between heat waves and mortality using a multi-stage Bayesian hierarchical model. And then the third component of this work, which I'm not going to get into today, but I'm also happy to talk about in more detail, was looking at effect modification by heat wave characteristics, again, applying a multi-stage hierarchical model. And what we found was very interesting. So this shows the relationship between temperature and mortality for each of these different communities across the region. And you'll see that depending on which city you're looking at, from Jaipur, which is shown in the graph at the top left, to Mumbai, which is shown in the graph at the bottom right, the different communities experience a different range of temperatures, which is shown across the x-axis of these graphs. But what we do see is that there is an increase in the relative risk of mortality for each of these different communities as you start to get into these higher and higher temperatures. And this is the case across all of these communities, although we don't see statistical significance in the case of Idhir and Ahmedabad, which I think is probably due to the smaller population sizes in those communities. But the most northern desertified cities of Jaipur and Churu experience some of the most dramatic extreme temperatures, reaching in excess of 45 degrees centigrade on a regular basis. And we do see that even though these communities experience higher baseline temperatures, we do have a corresponding increase in the risk of mortality as you get into some of those temperature extremes. So that serves to address one of the questions that we had at the outset, which is, do we really expect to see an increase in the risk of adverse health outcomes in these places that are already experiencing high baseline temperatures? And we still see the same is the case in Mumbai, which experiences a less extreme at the upper end of temperature in their temperature range, but we do still see an increase in the adverse health outcomes that are associated with increased temperatures in that city as well. So next, I was interested in identifying and characterizing heat waves. And as I mentioned before, there isn't a single definition of what constitutes a heat wave. So what I've done here for this portion of the project is I've applied a common heat wave definition that has been seen across the literature, which is applying both a duration threshold as well as a temperature threshold criteria. So if 2 consecutive days or longer are in excess of the 97th percentile of daily maximum temperature, according to that city's specific temperature record, that was characterized as a heat wave. And by comparison, the Indian Meteorological Department applies different definitions across different communities when they declare a heat wave period in different areas. It's dependent on the local climate as well as the baseline temperature. So what we did is we applied what I'm calling a modified Indian Meteorological Temperature definition for heat waves as the second heat wave definition for this study. And importantly, the IMD allows for single days of high temperature to be characterized as a heat wave day. And the reason why this is important is because we understand from the previous literature that the first day of a heat wave or single days of high temperature tend to have a less pronounced effect on adverse health outcomes than multiple consecutive days of sustained high temperatures. And so I was interested to understand what is the difference between the literature-based definition, the 97th percentile of temperature for at least 2 days, versus the IMD heat wave definition in terms of what we see as the health outcome. And so this just shows some of the differences in the numbers of heat waves that were declared across the different communities using this 97th percentile of temperature definition. And so the number increases from there if you're looking at the IMD heat wave definition, because there are more single days of high temperature that would be characterized as a heat wave. Sorry, I seem to have jumped ahead. And so what we found is that there were increases in the effect of heat waves on mortality, looking at the second or subsequent day of a heat wave using the 97th percentile of temperature heat wave definition compared with non-heat wave days, or looking at any heat wave day under the IMD definition. So we found increases in the risk of mortality associated with heat wave days versus non-heat wave days for all of the different communities in our data set. Although again, we didn't see statistical significance in the Idhir and Ahmedabad area because of small population sizes. But importantly, what I want to point out here is that depending on which heat wave definition you're looking at, you may see an attenuated effect or an effect that's closer to null using the modified IMD heat wave definition compared with the 97th percentile of temperature definition for heat waves. And I think this is important because it serves to underscore that depending on how you're looking at what a heat wave really is, you may have a different understanding of what the impact is of those heat waves on health outcomes. And so I think that this is really important from a policy perspective. Overall, across the 4 communities, the pooled estimate of risk was 18% higher on 97th percentile of temperature heat wave days compared to non-heat wave days. And using the IMD heat wave definition, once again, we saw a slightly smaller effect looking at heat wave days versus non-heat wave days. But so far, we've only looked at 1 or 2 heat wave definitions. And as I've mentioned, this can be very different. Your understanding of the health impacts of heat waves can be very different depending on what definition you use. So for the next phase of my research, I decided to expand the number of heat wave definitions that I was using in my analysis. So you'll notice here that I kept the Indian Meteorological Department's definition of what a heat wave is. But here I've looked at a variety of different temperature threshold criteria as well as duration threshold criteria. And I think that this has been a really interesting experience to run this study, because in this data set, we do actually have periods that are in excess of the 97.5 percentile of temperature for at least 4 or more days, which is an unusual characteristic of extreme heat wave periods occurring in this part of the world. To facilitate this work, I used a technique called propensity score matching, which is a causal inference method that aims to achieve covariate balance in regard to measured background covariates, i.e. potential confounders. So the idea of PSM is that this approach is intended to mimic some of the characteristics of a randomized control trial in observational studies. One of the limitations of this approach is that, of course, we can't control for unmeasured confounders. But this approach allows us to formulate clearly what is our causal question of interest, which in this case was, what would have been the estimated health outcomes on those heat wave days had the heat wave not occurred? And we do this by estimating propensity scores for each day and for each community in the study period using a logistic regression model that includes time varying confounders, meteorological characteristics, et cetera. We tested for the inclusion of these confounders based on a variety of different statistical interpretation plots. And we assessed whether inclusion of those confounders improved our covariate balance in the matched covariates. And what we found, in addition to using propensity score matching to estimate the relative risk of mortality for each of these different communities, I also applied another method to this study, which was to estimate the attributable number of mortalities that were occurring in each of these different communities. So we did this by calculating the number of days that were occurring for each of these different heat wave definitions that were of interest, and calculating the amplitude of the effect in addition to the relative risk of the effect. And what we found was actually quite interesting. So here I present a plot that shows on the right the relative risk of mortality that's associated with each of these different heat wave definitions. And on the left, I show a chart that has the number of attributable deaths that are occurring in each of these different heat wave definitions. And I know that this is a lot of information to show for all of these different communities, for all of these different heat wave definitions. So I just want to zoom into the city of Jaipur as an example. And what we see from this plot is that there are certain heat wave definitions that are very deleterious to human health from a relative risk perspective. However, those heat wave days occur very infrequently during the course of a summertime period. And so the amplitude of the effect, or the number of attributable deaths that are occurring under that heat wave definition, is relatively much smaller. And you might imagine that this is also an important finding from the perspective of public health practitioners who are trying to identify what is the right heat wave definition to actually use in our policies. And it turns out that it was. So I worked with local collaborators in different communities to generate this plot, which has the number of heat wave days occurring per year on the x-axis and the population weighted annual attributable mortalities. So taking into consideration that these are communities of varying sizes on the y-axis. And what you can see from this plot very clearly is that there are some heat wave definitions that are less stringent, shown in the lighter yellow in this plot, that occur relatively more frequently across those communities and across those different summertime periods, as compared with the more stringent heat wave definitions that are applied towards the darker red color. And so, we see a wide range in the number of days that are being declared as heat wave days, but we don't necessarily see as wide of a range in the amplitude of the mortality effect for these communities. So once again, I'll just zoom into the city of Jaipur, which is shown in the boxes in these three circles for correspondingly more and more stringent heat wave definitions. And what we see is that as we move from the least stringent heat wave definition shown in the yellow box all the way on the right, approximately 35 or so days per year are being declared as a heat wave day, which means that more than a month every summer is being declared as a heat wave in that city under that definition. And all of the corresponding resources that are required in this resource constrained area in order to implement public health interventions, those resources are required under this definition over a month every year. And by comparison, the more stringent heat wave definition being applied in the orange box shown in the leftmost circle has not that much of a change in the number of annual attributable mortalities that are occurring as a result of exposure to extreme heat. However, we've reduced the number of days each year that are being declared as a heat wave from 35 to just over 17. So we've cut down on the use of resources to declare heat wave periods in approximately half without correspondingly impacting health adversely by increasing the number of mortalities that are occurring. So this was very important for some of our partners on the ground who are doing this research to try and implement these different activities across these different communities. They were very interested to understand the trade-off between maximizing their public health impact and also minimizing the utility of resources that are required for declaring these different heat wave periods. So my own research to understand the effectiveness and evaluate the effectiveness of existing heat action plans has expanded beyond just this work that I've presented in India to look at similar heat action plans that have been implemented in different health settings in the US as well as around the world. So here I show one collaboration with other academic partners in South Korea and as well as some partners here in the US to look at evaluating the heat action plan in the country of South Korea. So in 2008, South Korea across different cities, I think 8 different cities in the country, they implemented a heat action plan that includes predictions of when upcoming periods of extreme heat will occur, and also a corresponding health protective program that is intended to try and minimize the impacts of extreme heat among the population in general, as well as for specifically vulnerable subpopulations. And what we found is that there was an impact of this heat action plan on health outcomes for a couple of different groups, including primarily people who are elderly, people who are living alone, and people who are blue-collar workers. However, in some of the other portions of the population that we looked at, we didn't observe similar effects of improved health during these heat periods post-implementation of this heat action plan. So what that suggests is that the benefits of the heat action plan and activities that are associated with the heat action plan may be under-realized in these different communities, which is an opportunity to improve public health. Similarly, I've participated in a collaborative effort to quantify the impact of changing the threshold of the New York City heat emergency plan in reducing heat-related illnesses in that city. New York City implemented a heat action plan, and in 2012, 2013, they started looking at changing the threshold under which a heat emergency is declared for the city. And what we found is that there was not a substantive change in the risk of morbidity across the city associated with that change in the temperature threshold, indicating once again that the benefits of this heat action plan may be under-realized in those communities. And now I've been very focused on the city of Boston, among other communities across the United States. I'm now working as an assistant professor in the Boston University School of Public Health. And the city of Boston does have an overall climate adaptation plan. So one of the things that I want to highlight here is that there are different components of these heat action plans that can themselves be examined to understand the effectiveness of these different interventions. So the city of Boston has this climate adaptation plan that includes components to try and protect populations in Boston during periods of extreme heat, such as what we saw in the most recent summertime period last year. And this includes, things like changes to building structures, changes to ventilation, and changes to heating and cooling systems to try and protect most vulnerable communities during periods of extreme heat. And one of the PhD students in our program at BUSPH in the Environmental Health Department, who is fantastic, Quinn Adams, she did a research rotation with me last semester, and she was interested in understanding the impact, the potential accessibility of one of the main components of a lot of different heat action plans around the United States and also around the world, which is the locations of these cooling centers. So during periods of extreme heat, one of the best adaptation strategies is to have access to air conditioning. And in different parts of the United States, for example, the penetration of air conditioning into residential areas is different depending on, the newness of structures and the previous temperature ranges that were experienced. So we might imagine that places like Boston would have different levels of individual air conditioning usage in homes compared with places in the southeastern US, for example. And so, at cooling centers, which provide access to cooled or climate controlled environments during periods of extreme heat to people who may not have access to air conditioning in their own homes, is a very important adaptation strategy that has been implemented in many different communities around the US. And we were able to obtain the locations from publicly available data of cooling centers that are a part of these heat action plans across 81 different cities around the United States. And this work is currently, under review. But what we found is that these cooling centers, by and large, are accessible within these different communities to some of the people that we might think of as the most vulnerable populations. But importantly, there's differential in some of the people that we might think of as very, very vulnerable, including populations who are older than age 65. So, once again, it provides opportunities to continue to improve these heat action plans to make sure that we're being protective of the most vulnerable members of our communities. Similar methods that I've presented here towards the end of this talk, looking at using geospatial information to identify access to different types of resources, can be used across different types of resources or different urban characteristics to evaluate not just heat action plans, but also to look at community level resilience and preparedness in the face of climate extremes. And so one other paper that I wanted to share is this one, which is again in collaboration with some of the academic partners in South Korea, to look at access to urban green space in terms of city parks. And what we were able to show is that there were differentials in access to urban green spaces in the city of Seoul at the different levels, different municipal levels that correspond roughly with wards and neighborhoods in Seoul, South Korea. And these differentials in access corresponded quite well with different types of community sociodemographics and other important characteristics that might indicate vulnerability. Similarly, we have also been using these GIS methods in the United States to look at access to different types of resources that might be considered important for community level resilience in addition to urban green spaces. This is an example that I provide, which was very recently accepted in the Journal of Exposure Sciences and Environmental Epidemiology, which shows that depending on the method that you're using There, you may have a very different understanding of people's access to different types of resources. Here, using grocery stores in the metropolitan Atlanta area as an example of multiple different methods for estimating access to grocery stores. But so, I've kind of reached the end of this line of research and this line of questioning. So some of you might be asking, well, you presented about this hospital at the very beginning. That was the impetus for this entire starting of this research agenda in India. And so I wanted to just journey back to the hospital to talk a little bit about what we were able to do specifically within that community. And what we found is that at the hospital, the roof of the hospital was covered in black coal pitch tar. And so you can imagine that during an extreme summertime period, when the sun is beating down on this non-reflective surface, it was very important for them to have this coal pitch tar in the roof during the monsoon season because it provided for adequate runoff of stormwater. But in the summer, it was creating these hostile conditions. And what we realized is that the maternity ward was on the top floor of the hospital. And so the conditions in this maternity ward were absolutely stifling to the point where the doctors weren't able to see multiple consecutive patients in a row. They would go into the ward and then come out and then go back into the ward and then come out. And so, a very simple local intervention that was implemented at this hospital is that the black coal pitch tar was replaced with this picture that I show on the left of white China mosaic tiles. And so this was an important local intervention because this China mosaic tile still allows for the runoff of the stormwater from the roof of this hospital, but because it improves the reflectance of the surface, it actually helped to reduce the temperature in that ward by a few degrees, even during these periods of extreme heat, which had substantive improvements in the health that was experienced among these very sensitive newborns in the maternity ward. Another local intervention that was implemented, which I've shown here on the right, is filling these clay pots that are made by local artisans with water and placing them on the roof, because as the water from those clay pots would evaporate, it would actually help to serve as a cooling mechanism for the different ancillary buildings around this hospital. And finally, this is from the paper that was published in 2014, again by Dr. Kakad, who is the pediatrician in this hospital. And what they did is they moved the maternity ward from the top floor of the hospital to the ground floor of the hospital. And they were able to, once again, achieve substantive improvements in the health outcomes and in the readmission of their young babies into the neonatal infant care unit in this hospital as a result of this simple change from the top floor to the bottom floor of the hospital. So I think that, this serves to show that in these situations where we're looking at the outcomes that are associated with these periods of extreme heat, sometimes the very local information and the local interventions can have a huge impact with minimum resources, especially in these environments where there aren't a lot of resources to begin with. So just in conclusion, to kind of wrap up, I know I'm running a little bit over my time, but I believe that what I've been able to demonstrate here is that there are opportunities to leverage existing data in this resource-constrained environment to provide public health interventions that can be potentially hugely impactful to local communities, and highlighting the importance of this local data collection and locally policy relevant public health research. We think that previously there may have been severe underestimation of the burden of extreme heat on health in the region. And again, even at the higher baseline temperatures that are observed in these communities, we still saw increases in the risk of mortality associated with periods of extreme heat. And I think that it's really important to keep in mind the policy perspectives that we have included in how we define what a heat wave is. So I would say that further study is needed to try and understand the impact of different heat wave definitions on how we characterize the burden of disease in the region. In the study that I conducted, we found very limited evidence of effect modification by different heat wave characteristics, which might be due to the small sample size. But I think that if we're able to systematically collect these type of data from around this region, we might be able to improve some of these studies to better understand what will happen both now and under a changing climate in the future. So with that, I just want to quickly acknowledge all of my different collaborators, both in the US as well as in India. And I'm very